Okay, you've done your screen exam, and now you've got the patient in there, and you want to review. You want to look at the cervical spine in detail now, and so like I said, I use this worksheet, and you can just follow along on that. The name and the occupation. Now, the occupation of the patient, especially if they have a postural dependent occupation, such as using a computer screen all day long, and the postural elements of that, and whether there's ergonomically positive or negative, those kind of things can have an effect on how you're going to overall treat these patients. Their chief complaint, again, will be on your screen exam, and this usually has to do with either local neck pain or radiating neck pain, scapular pain, anything up in the upper quarter, and so forth. The onset, of course, you get that also in your screen exam, and you want to know if there's an injury or whether it's an insidious onset. Okay. Your relevant medical surgical findings, many times these people will come to you with x-rays, they'll come to you with MRI reports, and those are all very relevant because they can lead you to the diagnosis of the tissue involved, and then further, of course, help you with what to do with it. Pain, paresthesias, again, this can be taken from your screen exam, and specifically you want to shade in where they're having paresthesias or where they're having hyperesthesias, where they're having pain, especially, and what's causing their pain. Your range of motion exam, I don't get real specific about ranges of motion, but I do look at generalized range of motion, so that on the movement chart, I just put in little dashes on each line of movement, and whether the pain is, I put a little caret on whether the pain is right or left or central, okay? And that gives me a little idea about the active movement of the patient and how it affects their pain. Pain with overpressure, again, you can do this to clarify your exam if you think the patient will tolerate it, and you have to be very careful with overpressure. You can actually have the patient do overpressure on their own, and that's a little safer. And sometimes this will clarify where the pain is exactly, and what movements are exacerbating the pain. You want to know what aggravates their pain and what eases their pain. Many times they will tell you, I can't turn to the right, the left is fine, can't turn to the right. And of course there you're dealing with, again, your intervertebral framing, your facet joint, and other structures. You want to list on this form your positive screen findings, and then what you think is wrong with the patient based on what you found here so far. It may just be a postural dysfunction phenomena. It may be a C6 radiculopathy, and it may be secondary to a disc or from arthritis or whatever, based on what objective proof you have. And then you want to get into a conclusion. Now, I also on the bottom of here have palpation findings, and I want you to make sure that you're comfortable with palpating these patients and what you're feeling and how to do that. I don't have a patient with me today, but I will kind of go through these things a little bit with my hands, and give you some techniques of how to palpate different structures and what you can palpate, what you can't palpate. If you have the patient lying flat here, you can palpate behind the mandible and just below the mastoids, and you can actually feel the patient's transverse process of C1. Now, if you want to, this is these processes are very painful. So you don't want, you can feel a little bump there. That's all you need to feel. You don't even need to really feel that. But that's where you can find transverse process of C1, right there. Okay. The next thing you want to find is a transverse process of C2. So all you do is you just come in around with your fingers in behind their head, and you palpate. You can actually feel many times. You have the patient, I usually have the patient's head either flat on the table or a little bit on my stomach. And I can feel right around where the atlas is, and you can, on many patients, you can actually feel the posterior arch of the atlas. And then right below that, you'll feel a large spinous process. And that is your C2 spinous process. It shouldn't be painful. It's easy to palpate. And then what you can do is let your fingers glide down away from the spinous process and onto the articular pillars of C2, C3. And then you can work your way right down those articular pillars. And generally speaking, if there's a problem at say C5, C6, you'll have a lot more pain right there where when you get over that articular pillar, and you'll note that it'll be very sensitive over C5 articular processes. Okay, so you can actually feel those the articular pillars of the facet joints in most patients. A lot of the patients that are really heavy and thick in the neck, it's much more difficult to find. But there is a valley there between the spinous processes and the transverse processes, and that's where you can actually palpate underneath all the muscle structure. You can palpate the articular pillars. Okay, so you need to be able to do that, and then you need to be able to palpate the patient's suboccipital muscles, and you can find most of them just by coming in and finding the occipital protuberance, and then coming down off of that, and between that and the spinous process of C2, you will find the suboccipital muscles, and you will many times find soreness, spasm, etc. with those muscles, and they can be treated with transverse friction massage. Okay, now I'd like to talk a little bit now about treatment of different kinds of problems. One of the things, when you're dealing with an acute neck, whether it's a radiculopathy or just an acute sprain, incidentally, with x-rays, anytime you see an x-ray with a reversal of the lordotic curve of the cervical spine, you know there's a problem. And you don't have a reversal of curve unless there's some kind of muscle spasm causing that. And the muscle spasm is a reaction to the problem, and straightened lordotic curve just means that there's something going on there. So in the real acute phase, some of these people are in just such severe pain that they can't sleep, they can't move, they have to generally sleep in a recliner, they can't lay down flat, and they're really, really painful for several days. And in this particular point in time, they're not ready for any kind of physical therapy treatment other than pain modalities such as heat, massage, electrical stim, TENS, that kind of thing. And then what is very helpful in this stage is a soft cervical collar. And the cervical collars are very helpful in this first acute stage in trying to manage their pain. And generally I generally reverse them so that they're not sticking way up in the air like this, so that their chin can rest on the collar and help support the head. And then in addition to that, I also use towel collars in the absence of a nice, commercial cervical collar that's properly fitted. And towel collars, I just tell the patient to take a regular dish towel, not a full-size terry cloth towel, just a smaller towel. Roll it up, wrap it around your neck. Use a safety pin, and that's what we call a towel collar. That also is very helpful during this acute phase. Non-steroidal and steroidal anti-inflammatory medication is really helpful, it usually takes a week or two after the acute onset for these people to start feeling better, that you can start mechanically treating them. Okay, so that's in the real acute phase, and immobilization is a good thing to do then. Moist heat transfer restriction massage, and I do use, depending on the problem, if it's a facet or if it's a radiculopathy, whatever, traction is usually very helpful. And I use manual traction to start with, and if we get a good reaction from that by unloading those tissues, then we may start them on a mechanical traction routine using the Saunders traction setup. And with that particular setup, you would like to get the traction kind of concentrated at the level of involvement. If you think it's an upper cervical problem, that's just mainly coming from some sort of a extension posture, and you just want to get some decompression of the upper cervical, you would do it in pretty much neutral flexion, and then you just adjust the flexion of the head based on where you want the concentration of the traction. The intermittent cervical traction that we use as a treatment modality, generally, like I said, we use the intermittent machines on them. Treatment times are usually anywhere from 20 to 30 minutes. Traction pulls, the pounds of traction are anywhere from 15 to 25 usually. We rarely go over that. And then we use maybe a 10-second hold and a 5-second rest intermittently. Traction is a valuable modality in the treatment of cervical spine syndromes, even whether they happen to be just postural or whether they're radicular in nature, whether they're arthritic in nature, whether you think it's actually a disc. Traction is indicated in all those patients, as long as you're not peripheralizing the pain and you're not getting any kind of weird symptoms from it. That's why I usually use manual traction to begin with, and there's techniques for doing that. You can do it lying down, you can do it setting up, and you can really gauge how much pull you're doing on the patient during the manual traction procedures, so that you don't have them lying there on traction for half an hour with them having more pain with it. So the manual traction is really a precursor of doing mechanical traction, and we usually like to get the patients in at least 3 times a week for that, and then at home have them follow up with a home program of exercises based on what you think is wrong with them. We use the McKenzie, pretty much all McKenzie cervical exercise programs that are, I'm not going to go into detail with them, but you're talking about the chin tuck exercises, and you want to get this particular movement going on almost every patient, because it is a pre-postural positioning of the cervical spine, and many times you can't do that though. You still have to use your peripheralization pain phenomena. When in the really acute phase, and you have your patients lying down or sitting up or whatever, and you try to do any kind of chin tuck exercise, excuse me, this many times will peripheralize the pain. Doesn't mean it's the wrong thing to do, it just means you can't do it yet. And so and there may be a different way of doing it. What we, on the real acute patients that it seems to be indicated to start on, what we'll do is increase the flexion with pillows before initiating the chin tuck exercise. So many times we will start with chin tucks with 1 or 2 pillows under the head, and they're able to tolerate that well. And then as they get better, you can take the pillows out, and eventually they'll be flat on the table doing chin tuck exercises, and you progress from that to doing standing, sitting, mirror assist chin tuck exercises, and you progress from there. they're fairly safe, and you're not going to hurt the patient much with them, and they are preparatory to doing other exercise programs, more aggressive postural treatment. And they do seem to be curative. You'll see symptoms disappear with them. All right. So that's the exercise routines that we use, and the traction. Again, using the peripheralization pain phenomenon, beginning and ending with postural control and positioning. Many things I have not even touched on that you'll get in your clinic here, that your supervisors will teach you and expand on what I've told you. What we've tried to do today is just give you a base of pathology and anatomy to work from, and treat these patients with neck problems. Okay, so that is the end of the program, and I wish you all well in your practice here with our physical therapy.